In this roll of electrolytes, which is something you have had numerous times, what you're going to see me do is skip ahead each time with each different electrolyte to the assessment and recognizing cues. We're going to start with hyponatremia. With hyponatremia, there are several common causes of it, and they are listed nicely for you in Table 13.4 on page 252. But now, let's go into the assessment and recognizing the cues that are the signs and symptoms of hyponatremia. Neurological changes include general muscle weakness. And remember, look at the action alert here where it says that if muscle weakness is present, we must immediately check for respiratory effectiveness to make sure that the patient is able to ventilate appropriately and using the strength of their respiratory muscles. The cardiovascular changes seen with hyponatremia are also those seen with dehydration, because a lot of times when your patient is dehydrated, when the fluid has left the body, especially by the use of diuretics, they also has taken the sodium with it. So with hyponatremia, what are some things that we would see? We would see the physician would usually decrease or stop their diuretics if possible, because a lot of times it's because of the fluid volume loss that it causes the hyponatremia as well. If the hyponatremia is severe, you also may see the use of hypertonic saline in small amounts, often about 3%. You'll see this always through a infusion pump when they do use 3% or greater saline. You'll also see some changes in their nutritional therapy. They may increase the sodium in their diet, but a lot of times, especially with our kidney patients who have hyponatremia, you'll see a restriction of their fluid volume so that the patient does not end up with fluid volume overload trying to increase their sodium levels as well. Moving on to hypernatremia. The common causes are listed for you quite nicely in Table 13.5, and this is on page 253. Going to move on to assessment cues. Again, with our neurovascular system, what will we see? We may see changes in the patient's attention span. They may be more agitated. You'll see in the skeletal muscle systems, you may see twitching or irregular muscle contractions as well. With the cardiovascular system, you'll see a decrease in contractility because the high sodium levels slow the movement of calcium into the heart cells. So, what interventions are we going to take? When a patient's sodium has a high sodium level, the nursing care priorities for this patient include monitoring their response to inpatient safety. Drug therapy is used to restore the fluid balance when hyponatremia is caused by fluid loss. Most of the time you're going to see that with isotonic saline, which is 0.9% saline, or you may see some D5.5 normal saline, things such as this. And we'll talk about this more on our day that we spend in our new skills lab. Nutritional therapy to correct hypernatremia may be simply a low sodium diet or a restriction of that sodium intake for the patient. So with that being said, the main things I want you to make sure you're looking at for sodium imbalances are those recognizing the cues and the taking action. That's going to be for all of your electrolyte imbalances. So now let's look at our potassium imbalances. We're going to start with hypokalemia. Hypokalemia is seen as a potassium level less than 3.5 milliequivalents. You're going to see again common causes of hypokalemia. common causes of hypokalemia on table 13.6. But what I want us again to concentrate on with our hypokalemic patient is what are our recognizing our cues with our assessment. Our assessment. When you have a patient who has hypokalemia, you want to make sure, like with any patient, that you're getting their drug history. Oftentimes, especially with our elderly patients, they will be taking drugs that will lead to potassium loss, such as diuretics or corticosteroids. And a lot of times, the provider will place them on potassium supplements. But you'll see that sometimes your elderly patient doesn't take their potassium supplements because they're too large or difficult to swallow, or if they've switched them to the liquid, they don't care for the taste. So you want to make sure not only what history of what medications are prescribed to the patient, but also what medications they're actually taking. So with your patient with hypokalemia, you want to look at the musculoskeletal changes. They could have weakness in their muscles. Cardiovascular changes could be where you have a thready and weak peripheral pulses. Sometimes you will see pulse rate changes from very slow to very rapid and an irregular heartbeat. You can see neurological changes, such as altered mental status. Intestinal changes are usually a decrease in peristalsis, which can lead to a paralytic ileus if it is not corrected. When you have a patient who has hypokalemia, you're going to see EKG changes. And those EKG changes are, you're going to see an ST segment that is depressed or flattened. Your T wave is going to invert and your U wave will increase. We'll talk about this more when we discuss EKG changes. But I do want you to be aware that your hypokalemic patient will have EKG changes. So one of the big things we're going to do, undertake action, is we're going to give potassium replacement. Now, how can potassium be replaced? Potassium can be replaced either orally or it can be replaced through the IV. When potassium is given IV for severe hypokalemia, you must be very careful with it. Under the Joint Commission National Patient Safety Guidelines, only a registered pharmacist can mix your potassium concentrates. Nurses can no longer mix these medications. Make sure you read the Nursing Safety Priority under Drug Alert on page 254. It's talking about when the medication, when potassium is given IV, the maximum recommended infusion is 50 to 10 milliequivalents per hour. That is generally what you'll see in piggybacks. You'll also hear them called K-runners, which is the 10 milliequivalents per hour. If the patient has a central line, which we'll discuss again in your new skills class, they can give 20 milliequivalents an hour. But that patient also has to be monitored on an ECG rhythm in most institutions. One thing we want to keep in mind with potassium is it's a severe tissue irritant. A lot of times patients have a hard time tolerating the potassium. They'll say it burns and it can be very uncomfortable to get through the veins. Because of this, and because it's such a severe tissue irritant, potassium is never given IM or sub-Q. If you always want to make sure you're checking your IV line prior to starting a potassium infusion. With that being said, if the potassium does leak into the skin, you of course want to stop that infusion, and you want to notify your provider, because potassium can be very irritating to the skin in general. Again, make sure you're looking at that nursing safety priority on page 255 under Action Alert. Moving on to hyperkalemia. Now, what are you going to see with your patient with hyperkalemia? You're going to see some nasty arrhythmias because cardiovascular changes are the most severe problems with hyperkalemia and are the most common cause of death in patients with hyperkalemia. Just to keep you, for the shock value of it, potassium is one of the medications used for lethal injection because it causes fatal heart dysrhythmias. So that's one of the reasons that when you have a patient who has severe hyperkalemia, you're going to be monitoring that very closely. These patients are always placed on a cardiac monitor because you're going to see symptoms such as bradycardia, hypotension. You're going to see tall, peaked T waves, a prolonged PR interval. You're going to see ectopic beats or PVCs. These are things that we'll talk about next semester. But you're going to see all kinds of different heart arrhythmias. For our purposes now, we just need to know that when a patient has hyperkalemia, they are more at risk for lethal heart arrhythmias. I hope that makes enough sense. So, what do we need to do for our patient who has hyperkalemia? So, with hyperkalemia, what interventions are we going to be taking? Well, drug therapy is key. The priority for nursing care for a patient with hyperkalemia is assessing that cardiac function and cardiac complications, monitoring that ECG rhythm, making sure that our patient is safe from falls, monitoring their responses to therapy, and making sure we're doing health teaching. The oral drug Patamir binds with the potassium in the GI tract and decreases the absorption. This is one drug therapy that is used. If the patient's hyperkalemia is severe, they will be placed not only on the EKG monitor, but in a critical care unit where they can give both glucose and insulin at the same time, forcing that potassium out of the cells. When assessing our patients with hypokalemia, one indicator is frequent and painful muscle spasms, or like Charlie horses in the thigh or calf or foot when at sleep or at rest. Most symptoms of acute hypokalemia are caused by overstimulation of nerves and muscles. So therefore, you want to ask about recent surgeries, whether it be orthopedic, thyroid surgeries, or other surgeries of the upper to middle chest. Chronic hypokalemia can lead to skeletal changes, such as with decrease in calcium caused by loss of bone density and osteoporosis. With this being said, the bones are less dense and more brittle. So, what interventions are we going to take with our patient with hypokalemia? We're going to do calcium replacement. We're going to encourage them to eat calcium-rich foods. We're going to make sure that we follow fall precautions to prevent injury with our patients with hypokalemia. And we'll talk about this a lot more when we talk about osteoporosis in a few weeks. I'm going to finish this off on the next set of recordings. We'll cover hyperkalemia and the magnesium imbalances at that time because we're running out of room on this one.